Hello and welcome to another Pipecast. Today we're going to look at Tackyarrhythmias. Now this algorithm go hand in hand with our quick ECG interpretation considerations for ALS. Okay, where we look at ventricular rate, ventricular width, and we follow a protocol from there basically. Okay, so these algorithms are the ones with output. Okay, not good output, but they obviously have output, so they have a pulse, because if they didn't, then you jump straight back into one of the other two algorithms that we just talked about. Okay, so when you're dealing with a patient, your normal things always apply. Okay, so your A, B, C, D, E's always apply. So make sure they've got enough oxygen, make sure they've got enough perfusion, make sure you've got monitoring, IV access, bloods if you can do it. Think about all of these things. Now, if you are starting to see adverse effects to their condition. Okay, they're tachycardic. Okay, great. But if it's a problem, then we need to start looking into it. Now, the way that we define problems is obviously looking at adverse effects. Now, the ones written on your screen, they're not the easiest to follow, because shock, syncope, I mean, you're like, that's great. So what we're really looking for is a reduced level of consciousness and a systolic blood pressure that's less than 90, okay, or basically an altered level of consciousness with a lower systolic blood pressure. Ischemic myocardia, that can be translated as chest pain and evidence of heart failure. So ECG evidence of heart failure, or history of heart failure, then we go from there. Now, if any of these unstable features are in place, so therefore they've got perfusion problems, they've got output problems, then we go straight for cardioversion. Okay, now depending on the cardioversion, will obviously depend on how much joules we go through, but you do direct current up to 3 attempts. Once you've done the 3 attempts, then you move on. Okay, you move on to the other treatments. Okay, now when you're dealing with cardioversion, this has to be done with sedation on board. Okay, so you don't do it dry. That's just mean. So depending on what rhythm you have will depend on how much current you put into them. Now, the numbers that I give you are generalized numbers that are adopted by most areas. Okay, you work in different areas, it can change. Okay, but these are just considerations. So if you have a narrow QRS complex that is regular, then you can give 50 to 100 joules. If you have a narrow irregular, then it's 120 to 200 joules. Okay. A broad regular is around 100, and a broad irregular is basically your defib. So only when you have a broad irregular QRS rhythm, tachyrhythm, you defib, and you don't have to worry about synchronization. Okay, the other three, you're generally looking around the 100 mark for the regular rates and 120 to 200 for the irregular. Okay, so that's cardioversion. Now that's obviously down and dirty, something you need to talk to your staff that you work with in order to practice cardioversion. It is pretty simple, granted, okay, but it's still something that needs to be practiced. Okay, and you need to start talking about what sort of things you're going to use for sedation. Once you've gone through the cardioversion and it doesn't help, then that's where you need help. Okay, if the cardioversion didn't do what you wanted it to do, then you need to seek advice. Okay, because that's when we're going to give amiodarone, this time over 10 to 20 minutes. Okay, so not your push that you're used to with your ALS protocol. This is an infusion over 10 to 20 minutes, 300 milligrams. And then you repeat the cardioversion. If that still didn't work, even if it did, you're probably going to give an infusion of 900 milligrams over 24 hours of amiodarone as well. Okay, and that will help stabilize the whole QT. Okay, if you're dealing with tachyarrhythmias, you want to reduce that. It means you want to prolong the QT interval. So amiodarone, as you could imagine, is a drug of choice, absolute drug of choice. Now, if at any stage the cardioversion or the drugs you give essentially takes away those adverse effects. So now you have a stable arrhythmia, okay? A stable tachyarrhythmia. You can either have it from the start, basically means no signs of loss of cardiac output or chest pain, no history of heart failure, then you can move straight for the stable side of the house. Now, when you're looking at stable, you've obviously got time. So you can go back to this and you can look it up. The first thing we need to look at is the QRS, how wide or narrow it is. So if it is greater than 3 squares, then it's considered broad. If it's less than 3 squares, then it's considered narrow. Pretty simple. So looking at the broad QRS, okay, because they're basically the worst, okay? They're the most likely to turn into your VTs, realistically. They're the most likely to have complications with them, is your broad tachyarrhythmias. Okay? Once you've established that it broads, you need to look at the regularity. Okay? If it's irregular, then straight away you need professional help. Okay? You could have atrial fibrillation with a bundle branch block. Okay? Or you can have atrial fibrillation that's been there for a long period of time. Okay? Either way, you need to start treating, you need to start monitoring, because long-term AF has complications. Okay, so we won't talk about AF just yet, because that will move into our irregular narrow complex tachycardia. Okay, but either way, if it's irregular, you're looking at the starting points of your VFs, your Torsades, that sort of thing. Okay, so you need to essentially seek that professional help. So when you're dealing with your polymorphic VTs, so your Torsades to points, okay, most other tachyarrhythmias will be given amiodarone infusions. Okay, at some stage they will get an amiodarone infusion most of the time. Okay, but when you're dealing with your Torsades to points, obviously you do not give amiodarone. Okay, you give 2 grams of magnesium over 10 minutes. Okay, because Torsades to point is caused by prolonged QT, so you don't want to exacerbate that. Okay, you're more than likely to give them asystole if you do that. Now, if your broad complex, your broad QRX complex is regular, then you look at pulsed VT for starters, and that is treated with amiodarone. 300 milligrams for starters, this time given over 20 to 60 minutes. Okay, so it's a longer infusion because you have the stability, you have the cardiac output, therefore you don't need to push it as quick as you did when you didn't have decent cardiac output. So it's over 20 to 60 minutes, and then your 900 milligrams over 24 hours. Now, you will read around the world, that amiodarone is stable with normal saline, with Hartmann's, and it can be administered with either safely. Okay, but the Australian Injectable Handbook still has it written that it must be given with 5% dextrose. Okay, so despite what you read, despite all the evidence out there, Australia hasn't picked up on it, so we're still giving it with 5% dextrose. And it's not probably not going to do any harm. Okay, just make sure you've got 5% dextrose on board for an infusion of 900 milligrams over 24 hours. Okay, so just consider it, because it's not only amiodarone is not only used in the case of a shockable rhythm. Now, if the person has a history of SVT and a history of your bundle branch blocks, then you move over and you treat it as though it was a regular narrow rhythm. So just to recap our broads, if it's irregular, then you consider amiodarone for long-term pre-existing AF, magnesium for Torsades to points. If there's evidence of a bundle branch block with AF, then you move over to the irregular narrow algorithm. Same too with the regular algorithms. If there's presence of a bundle branch block, therefore it makes it look that little bit wider, then you move it over to the regular treatment of the narrow QRS complex. Okay? If there's no evidence of bundle branch blocks, then you treat as a pulse VT, and the main treatment for that is slow infusions of amiodarone for 20 to 60 minutes, and then a 900 milligram over 24 hours. So moving over to your narrow. So when you see narrow QRS, most people will consider this to be like your SVTs. That's the most common narrow complex tachycardia is your SVT, and that falls into the regular category. Okay, so if you have a regular narrow QRS complex tachycardia, then you treat it as though it's SVT. Easy done. Now with SVT, we all know our vagal maneuvers, our extraprimordial maneuvers. That's where you get them to bear down, that's where you get them to blow up a syringe, where you increase those baroreceptor pressures, hoping to stimulate the vagus nerve. Okay, so we've all done them. What most people may not know is just the Valsalva maneuver has a pretty low success rate. Okay, but to increase the probability of that success rate by 40%, then a simple technique can be implemented, which is raising the person's legs. Okay, so if you raise the person's legs, you're encouraging preload within the heart. Therefore, you get something known as a Frank-Stahl's effect, and you increase the probability of the vagal maneuvers picking up and slowing that heart rate down, because you've already increased the pressure within the heart before you've increased the pressure external for the vagus nerve to kick in, to have that parasympathetic pathway established. Okay, so very simple maneuvers, non-invasive, no drugs, all good to go. If after that it doesn't work, then we move into our adenosine. Okay, so adenosine is given, and obviously that chemically restarts the heart. Okay, quite scary to see, quite scary for the patient, so you need to explain it to them. But you'll give 6 milligrams. Now rapid, which means you'll push that 6 milligrams as fast as possible. You'll see the effect on the ECG, and hopefully you'll come back. If you come back and it's still SVT, then you give a further 12. If that doesn't work, then you give another 12. Okay, obviously always monitoring the ECG as you're giving this and being with the patient. Okay, if after that sinus rhythm hasn't kicked in, then that's where you need lots of help. Lots of help, okay? And then they can start looking at things like beta blockers to physically slow that heart rate down from a different pathway. If it is a sinus rhythm, okay, then you can need investigations from there and looking at stopping it occurring again. Okay, but once you get that sinus rhythm back, it's obviously no longer SVT. True. So then you'll start looking at preventing it happening again. Okay, things like ablation, medications, that sort of thing. Okay, so that's your pathway for your regular narrow tachycardia arrhythmias. When you move into your irregular, okay, so obviously irregularities have a little bit more, I don't want to say danger, but they're more likely to have less output associated with them. Okay, so then we need to look at the probability of AF, because that's what we considered before. With the broad QRS, it's moved over to here. So with AF, we need to know how long AF has been in place. Okay, because if it's longer than 48 hours, then you're going to have to start looking at anticoagulation protocols. So if it's longer than 48 hours, then they get anticoagulation medications. If it's not, then it's usually controlled with beta blockers or calcium channel blockers. Okay, that's what controls it. If there's presence of heart failure, then you'll start looking at your digoxin. Okay, that will physically slow the heart rate down. Okay, has that negative chronotropic effect, and then your amiodarone. Okay, again prolonging that QT interval that we have, being mostly a potassium channel blocker. So that's your narrow QRS complex treatments. Most likely it's going to be SVT. If it's irregular, then obviously a lot more considerations need to come into place, whether it's a heart failure, prolonged AF, non-prolonged AF, need beta blockers, calcium channel blockers, digoxin. Okay, there's a lot more considerations to look into play. Okay, so when you're dealing with irregular rhythms, as I mentioned, it usually comes with a lot more considerations and a higher probability of losing output, which is the big problem. Okay, so that's your tachy algorithms. I do not expect you to remember it at all, but know that they exist. Know that you can go through them, and you can start practicing them as well. Start talking about them too, okay? Because SVTs are quite common in our world as well. And until next time, take care.